Thank you.
Thank you, sir. Next, I call upon Dr. Reesha. She is a senior consultant in the Department of Uvea at LF Hospital, Angamali.
Thank you, Rahul. I'll show you algorithm for a case of posterior uveitis. Here there are some examples of posterior uveitis. All look very much similar, but they have different etiologies. Some are infectious, some are non-infectious. Here comes the role of correct protocol so that we can prevent the permanent vision loss. And this is the protocol for the management of posterior uveitis. First, describe the uveitis, then mesh it, comparing the existing diagnosis, and general and specific lab testing to evaluate the patient, then specialist consultation to confirm the systemic disease and start treatment. Then start treatment, then follow up. How to describe the uveitis in terms of age, chronicity, anatomic location, laterality, severity, depending upon the pathology, pattern of uveitis, and depends on the etiology. After reaching the etiologic diagnosis, treatment depends upon the anatomic location, whether it is anterior, intermediate, or posterior, whether it is only ocular disease or if it is associated with any systemic illness, and whether it is infectious or non-infectious. I'll give you some examples. This patient presented with a young male presented with vitreous clouding. So that was a case of posterior uveitis. The systemic evaluation was within normal limits. Uveitis specific history and investigations all were normal. But he gave history of IV drug abuse. So we suspected infectious etiology. ACTAP PCR was sent, came to be positive for fungal genome. He had undergone vitrectomy with intravitreal antibiotics. So the whole treatment is over. Next, see this lesion, it's very clear that the lesion is far behind. It's a choroidal lesion. OCT confirms the anatomic location of the lesion. And here the patient was young and pregnant also, 7 months. She had a history of contact, TB contact, her mother and sister. So Manjo was done, was positive with raised ESR. She was treated only with ATT, and this was the picture after 2 months of ATT. And see, this is yet another type of lesion. Here it is retinitis, not like choroiditis as in the previous case. Whenever you see retinitis lesions, always rule out viral etiology. This patient was on immunosuppression for vaginous granulomatosis, and ACTAP PCR came to be positive for CMV virus. So she was treated with intravitreal ganciclovir, and physician reduced the dose of immunosuppression. Yet another lesion. This is not a full thickness retinitis, but it's not a choroiditis lesion also. OCT shows deep retinal involvement. FFA shows disc edema and vasculitis. Patient was evaluated for all the causes of retinitis, especially atypical cases. VDRL and TPHA came to be positive. Patient was referred to dermatologist for crystalline penicillin along with steroids, and lesion completely resolved. This patient was referred as post-fever retinitis, but on meticulous examination was found to have high BP. A 23-year-old male, high BP with raised renal function. So that was a case of hypertensive retinopathy. Again, another patient with a hypopyon uveitis with vitritis and vasculitis with painful aphthous ulcer, referred to rheumatologist for treatment of Behçet. This patient only ocular illness with bilateral panuveitis, pinpoint leaks with late pooling, And skin and hair changes, no need to refer to anywhere, you only treat with the steroids and immunosuppressants. Another patient with bilateral occlusive disease, occlusive vasculitis with malar rash, again send the patient to rheumatologist for SLE evaluation and treatment. Another patient with granulomatous uveitis, candle wax dripping and snowballs with skin lesions. Refer to pulmonologist or rheumatologist for evaluation of sarcoidosis and further treatment, and monitor the ocular condition. Always these ocular signs will give you some clue regarding the diagnosis. Whenever you see granulomatous capes, rule out TB sarcoidosis, and pigmented capes, rule out viral etiology, and this type of crenulated capes, stellate capes, fuchs should be kept in mind. And another patient with pan uveitis in one eye and other eye history of trauma or surgery, rule out sympathetic ophthalmia, again no need to refer anywhere, start steroids and immunosuppressants. And this patient was treated as intermediate uveitis initially with systemic steroids, but on careful indirect ophthalmoscopy revealed an active toxo lesion in the mid-periphery. So start antibiotics with steroids in these cases. And try to identify different patterns so that you can come to the diagnosis easily, like all this. And think about non-uveitic conditions also. This patient had chronic uveitis, but all symptoms started only after cataract surgery, and on careful examination you can see these plaques behind the IOL. So that was a case of P. acne and off. And do not miss subtle changes of reactivation. In these cases, investigations, especially autofluorescence, helps in detecting this early reactivation in these cases. And here comes the role of imaging. This is a case of juxtapapillary toxo lesion. OCT shows the retinitis lesion, but CFFA shows an associated BRA also. So to summarize, whenever you see signs of uveitis, complete history and review symptoms is a must. Then detailed ocular examination with systemic evaluation, then classify according to the anatomic location and list the differential diagnosis and do stepwise diagnostic workup. And whenever you have a doubt or you are not getting enough outcome, then go back to the history again and do everything again. Thank you.